Question 1. In patients older than 85 years, which of the following is the most common symptom during MI? A. Chest pain. B. Dyspnea. C. Syncope. D. Altered mental status. E. Fever. Answer is B. Dyspnea. Summary. Answer B. Elderly, diabetic, and female patients frequently have atypical anginal symptoms. The extreme elderly, 85 years, experience shortness of breath as the most common symptom during an MI. Nausea, typical chest pain, syncope, and fatigue may also be present. The emergency physician can never clinically rule out the diagnosis of acute coronary syndrome in elderly patients just because they lack frank chest pain. Choices D and E occur more frequently in dehydration and infection than in MI. Question 2. Which of the following occurs in most patients with myocarditis? A. Chest pain. B. Fever. C. Antecedent viral syndrome. D. S4 heart sound. E. Leukocytosis. Answer is C. Antecedent viral syndrome. Summary. Answer C. Myocarditis is most commonly post-viral, including Coxsackie-B adenovirus and influenza. Bacterial and protozoal pathogens are less common etiologies. More than half the number of patients report an antecedent nonspecific viral syndrome. Acute symptoms include myalgias, fever, fatigue, chest pain, and shortness of breath, but none of these is present in most cases. Myocarditis may lead to dilated cardiomyopathy, causing overt heart failure. Leukocytosis is uncommon, EKG findings are nonspecific, and echocardiogram may show evidence of global hypokinesia. The gold standard for diagnosis is endomyocardial biopsy, but there are many false negatives due to the patchy nature of the inflammation. Question 3. Which of the following is the most common dysrhythmia in pediatric patients? A. Atrial fibrillation. B. Atrial flutter. C. Complete heart block. D. Paroxysmal supraventricular tachycardia. E. Ventricular tachycardia. Answer is D. Paroxysmal supraventricular tachycardia, PSVT. Summary. Answer D. PSVT is the most common cardiac rhythm disturbance in pediatric patients. Children are more likely than adults to have an accessory pathway as a cause, but reentrant AV nodal rhythms are common in older children. Treatment involves vagal maneuvers, adenosine, and AV nodal active agents in a stepwise manner. As in adults, unstable tachydysrhythmias necessitate electrical cardioversion. Atrial fibrillation and flutter are rare in pediatric patients without structural heart disease. Complete heart block is uncommon in children. Ventricular tachycardia is less common than PSVT in children. Question 4. Which of the following is true regarding control of hypertension and stroke? A. Patients with both ischemic and hemorrhagic strokes should have their BP reduced to a SBP of 140 to 160 mm Hg or pre-stroke levels. B. BP should not be controlled in any stroke patient unless the patient is a candidate for tissue plasminogen activator, TPA. C. Only patients with ischemic infarcts should have their BP reduced to a target SBP of 140 to 160 mm Hg or pre-stroke levels. D. Only patients with intracerebral hemorrhage should have their BP reduced to a target SBP of 140 to 160 mm Hg or pre-stroke levels. E. All stroke patients who experience clinical deterioration in the head should have emergent BP control to a target SBP of 140 to 160 mm Hg or pre-stroke levels. Answer is D. Only patients with intracerebral hemorrhage should have their BP reduced to a target SBP of 140 to 160 mm Hg or pre-stroke levels. Summary. Answer D. Patients with ischemic stroke should not have their BP reduced unless they are either candidates for TPA, have concomitant aortic dissection, MI or renal failure, or their pressure is above 220 by 120 mmHg. In fact, hypertension is probably neuroprotective in patients with ischemic stroke by ensuring that cerebral perfusion pressure is maintained. In contrast, patients with hemorrhagic stroke should have their BP reduced to a target SBP of 140 to 160 mm Hg, or the patient's pre-stroke level if it is higher. Lowering the BP in such patients may reduce the stimulus for bleeding and prevent hematoma expansion. Because prognosis in patients with intracerebral hemorrhage is tightly linked to hematoma volume, strict BP control may have a dramatic positive effect in such patients. Question 5. A 57-year-old female with a history of tobacco abuse, hypertension, and end-stage renal disease on hemodialysis through a left upper extremity arteriovenous fistula presents from her dialysis clinic with a chief complaint of chest pain. The pain began 3 hours after the start of her session, and enough fluid was removed to bring her close to her dry weight. She has no associated shortness of breath. Her vitals are stable. The initial EKG demonstrates nonspecific changes. Her chest X-ray is normal. Her subsequent blood tests reveal an elevated CTNI of 0.83 G per ml, reference normal 0.49. She was given 4 chewable 81 mg aspirin upon arrival to the ED. Which of the following is true? A. A cardiac troponin T should be ordered because it is more specific for myocardial infarction in patients on hemodialysis. B. The patient has had anestomy and appropriate treatment should be initiated. C. The troponin is likely falsely elevated. D. The MB fraction of creatine kinase should be ordered because it is the most specific test for myocardial infarction in patients on hemodialysis. E. Specific treatment for anestomy should be withheld since only serial, repeated enzyme elevations are diagnostic for a myocardial infarction. Answer is B. The patient has had anestomy and appropriate treatment should be initiated. C. The troponin is likely falsely elevated. Summary. Answer B. Falsely positive and non-diagnostic elevations of serum troponins and creatine kinase are common among dialysis patients. However, CTNI is much more specific for myocardial injury than either cardiac troponin T, CTNT, or the CKMB. In a large trial of asymptomatic dialysis patients, only 0.4% had CTNI values greater than 0.6 μg per L. In smaller studies of patients with suspected myocardial infarction, there has been no trend in false elevations of CTNI. While it is true that the most specific finding for myocardial infarction is serial elevation of CTNI, an initial significant elevation in the setting of a history, and findings suggestive of anestomy should prompt initiation of appropriate treatment. Delays in treatment and poorer outcomes are common among patients with end-stage renal disease, in part due to the mistaken belief that most increased CTNI values are falsely elevated. Even among patients without chest pain, there is increasing evidence that elevated troponin is correlated with increased short and long-term mortality due to significant cardiac events. The etiology for this finding is not entirely clear.